Hey Jeff, welcome back to episode 2. It's great to see you. How are you?
I'm pretty good, thanks, Aaron. Thanks again. I'm so pleased to be doing this.
Beautiful. Me too. And I'm excited to talk about what we are going to be talking about today. It's one of my favorite pieces of research that you've done. It's called The Dollars and Cents of Restraint. Now, I would love it if you gave a bit of an intro to this paper because it's going to inform the rest of our chat today.
Terrific. So the notion of, or the economic notion of the use of restrictive practices at that time in Australia is not well known. Um, so I've been collaborating with Janice LaBelle, one of my authors, some of the authors in that paper. Uh, Janice is part of the United States SAMHSA, the Substance Abuse Mental Health Services Administrators. And they've been doing a lot of research about the cost of restraint use. So we've been lazing getting got together. And one of the things, it also dawned on me that um, when we talk about human rights, we talk in its application, and rightly so, to the people that we serve, the clients at that time or participants today. But we often forget that human rights also has an application for senior management, for the people who do the accountants, your CFOs. They have a role too. And so it just dawned on me that, okay, what if we demonstrate that to actually the to apply a restraint is actually costly. There's no economic benefit. It's an economic cost, and so that's how it came about. And um, even if you look at it today, um, and in the NDI's landscape, we are very heavily regulated. And the cost of reporting your reportable incidents, your complaints, submitting your URPs, all of them, if you do a time and motion study, they are an economic cost to the provider, and nationally to the commission and to the country. Uh, so a second reason for me was also how do we convince the people who do the bean counting that they have a role and that it makes economic sense to reduce and eliminate and not to use restrictive practices. So that's how it came about. And this research actually led to further research on mindfulness-based positive behavior support that I've been collaborating with Professor Nirve Singh in Virginia in America, and we've been collaborating for a long time. Uh, how mindfulness-based positive behavior support started um, is, I think, like every one of us, we come to a point in our realization that what if we stop acting on, prodding, probing on the person with the disability? What if we actually intervene, not on the person with disability, but if we intervene on the families, the support workers, and then that's how the mindfulness-based positive behavior support started, um, where we took a different shift, uh, and to begin with, the change has to come within ourselves as practitioners. Some of the well-known saying, um, be the change you want to see in the world. And I'm a big fan of that saying. That's one thing. The second thing, then, one of the things as we were, when I was talking to my colleagues, international colleagues, on mindfulness-based positive behavior support, one of my argument is, okay, how can we demonstrate not only will it lead to the reduction of the use of restraint and seclusion, not only will it lead to a increase in positive behaviors, uh, how would it demonstrate that it will reduce stressed staff stress, for example? It will reduce staff stress, And how does all of this actually mean? What are the organizational benefits? So, how does an organization benefit from investing in a particular treatment, for example, and whether it makes sense? So, the mindfulness-based positive behavior support has actually demonstrated there is not just a reduction in staff stress, but a reduction in staff absenteeism, a reduction in work hours lost, and more importantly, particularly in Australia, a reduction in insurance premium.
Really?
Yeah, so the studies we did in America actually demonstrate that. The studies we did in Australia, at the Brooker et al. Paper, the two papers that we did in Australia, that showed a reduction more in restraint use and staff stress. And the later work demonstrates organizational benefits. So, so for me, human rights also can be applied in a very common sense way on what are the economic benefits for the organization.
And that's the way that an organization is going to understand it. It sort of reframes the way that they can think about support as well, because there is a commercial reality to this. They're almost two sides of the same coin.
That's right.
That there's the human rights element, and then if you can tie that to an economic sort of impact as well, I can imagine that would be received much more openly and broadly by organizations.
Yeah, and for me, if you look at it, if you think about it, in a very sort of pragmatic and common sense, and rightly so, it's not just a reduction, elimination of restraint and exclusion on the person, but what economic benefit it is for the organization to invest in that, treatment to reduce and eliminate restrictive practices. Uh, um, in a couple of my careers, I actually have done training on human rights to accountants and the finance team,
Really?
and the role that they play in enlivening human rights in the organization. Because there's a perception that, oh, human rights only apply to at the practice level. It doesn't apply to me as in a finance team or an accountant. It does. Or even human rights applied in HR, for example. So there is a perception that human rights only sit somewhere else, but it actually applies throughout the whole organization.
And how it can be championed at
That,
every
yeah,
level.
yeah. I, I'm actually kind of also interested, Aaron, in your role. Um, as a practitioner and as a founder and a managing director or co-managing director of Bespoke Behavior
Yes.
Support, uh, how do you in your practice, uh, especially for a practitioner, how do you communicate effectively about uh, restrictive practices, um, particularly with the people around the participant, the families, the support workers, and other professionals?
Yeah, this can be quite a confronting part of being a PBS practitioner.
Mm.
I think like we all come from such different backgrounds, different levels of training, and all of a sudden day one you're trying to communicate again or trying to work out whether something goes against sort of the human rights of somebody, and that's such a huge deal to have that in your head as you try to work out. You're trying to learn the nuts and bolts of the NDIS, like what is a coordinator, what do they do,
Yeah.
what's my role, and then on top of that you've also got this human rights element. And the way that I think about it and communicate about it with my team is that we're really almost like a mouthpiece for like the World Health Organization. Like we carry a lot of weight. The reports that we
Mm.
do, the restrictive practice identification, it's a huge part of our role. For me, I think that timing is really important. I think timing beats context.
Yes.
It's more important than context. So I feel
Mm.
like having open, frank, and
Mm.
honest discussions with stakeholders, with families, I think that has to happen as soon as we engage. It shouldn't be done in response to. And I
Mm.
think once that conversation is open, then it makes everything a lot smoother and easier to communicate about. I also think that it's really important to, like, when I'm communicating with a family, like when I'm a practitioner and I'm
Mm,
communicating with a family, I'm
mm,
going back to function. I go back to function all the time.
mm,
So when we're talking about restrictive practices, we're talking about seclusion, we're talking about chemical restraints. I'm going back and I'm thinking, what is the function here? So when I am doing like an FBA, if I'm doing some really deep sort of behavior analysis, I'm trying to link it back to that restrictive practice as much as I can. I find sometimes that newer pracs, they sort of divorce the two,
yes.
but I think that it's really important to have them together. From a more technical standpoint, when I'm a practitioner, like a question that I find really powerful is, what does this look like in 6 months if the restrictive practice is still being implemented on the participant? And I think that that is really important because it shows that we're not developing skills potentially. If there's no skill development, there's no attempts to reduce the restrictive practice, then it's kind of just a band-aid. And we're
Mm,
not going deeper, we're not going underneath, we're not trying to work out like what functionally equivalent replacement behaviors we could implement or what strategies are there to reduce the restrictive practices as they are.
mm.
Um,
Yeah, that's a critical insight, Aaron, that you've brought up about at the starting point, isn't it? It's about building that therapeutic relationship with the participant and
mhm.
the people around the participant. I also like your point um, about monitoring. Okay, what does it look like 6 months later? Um,
Mhm.
um, I'll be honest, not many plans that I've read. Actually, from when I read the plans, I don't think that concept springs to their minds, um, because for a range of reasons, from regulatory compliance, time, uh, it's become more process driven. You
Mhm.
know, I'm going to launch the plan. Hey, kind of finished, right?
Mhm.
So, phew,
Yeah.
next.
Next. No, I feel you. I think that there is such a gap there because it does feel like, especially if you're a new prac, it's a weight off the shoulders. Like,
Mm,
oh, I'm done. Like, I don't have to look at this plan again. I've sent it back 4 times for changes from my TL and my team lead,
mm,
sorry. And
mm,
I'm so happy to be done with it, and that's it. And there's sometimes the implementation of that plan or the forecasting done on that plan. It's not thought about as heavily as it should be when when writing something.
mm.
Um, in your paper, there wasn't a huge focus on chemical restraints. So, how do you think about chemical restraints, medication, within this framework that we're talking about?
Mm, um, when you look at the international literature, um, and many people have heard me say this, even when I was the inaugural senior practitioner during that time, um, psychotop- psychotropic medicine is a prescriber problem. It's not a provider problem. I have heard medical practitioners tell me, families want, the use of sedatives, or support workers even ask for sedatives for the for the for the participant, uh, and hence I think it's not just a problem in disability. The use of chemical restraint, in my view, there's an overuse of chemical restraint, not just in disability, but in child protection, in children's services, in older persons. Um, I have predicted that unless we change the paradigm on how we, and I'll use this term, how we regulate the use of psychotropic medicines, uh, then we will continue to see a rise in um, the prescribing of psychotropic medicines to control behavior. Of course, in the NDIS quarterly reporting, um, environmental restraints has overtaken chemical restraint.
Mm.
One of the problems why I still putting environmental restraint aside for now, um, chemical restraint will always be a problem because medical prescribers, when it comes to the prescribing of psychotropic medicines to people with disability, it is only a clinical guideline. Technically, there's no enforcement. So, if you recall, a few years ago, three commissions, the NDIS Quality and Safeguards Commission, ACSQHC, and the Aged Care Commission, we produced a joint statement on the overuse of psychotropic medicines to control behavior in older persons and disability. ACSQHC produced terrific clinical guidelines, but it's important to realize the clinical guidelines do not have an enforcement approach, a regulatory approach. If I look at if I situate the use of chemical restraint internationally, you see, for example, in the United Kingdom, they've been trying for many years in putting out guidelines after guidelines, even, for example, from the days of the National Institute of Clinical Excellence, produced some of the best guidelines on safe prescribing. It hasn't worked. Now they have in the UK, they have a STOMP project, Stopping Overuse of Psychotropic Medicines for People with Learning Disability and Autism. It's still, for me, a guideline. I still don't think it's going to have, if going to be effective in reducing the use of chemical restraint. So if I look even in America, if I look at all the different jurisdictions around the world, there are very nice guidelines. I am work and have collaborated with Professor Shumithro Deb, who's at the moment visiting professor at the Imperial College London. We worked together for many years. And he and some other authors has produced the World Health Organization clinical guidelines on prescribing psychotropic medicines. Very nice international guideline, written several years ago. It still has no effect. So for me, the one way to have effect is not to approach, in my view, not to approach chemical restraint as a chemical restraint, but we should flip the paradigm. And for me, the overuse of psychotropic medicines should perhaps be looked at from a public health model. So in a public health model, it's about prevention, right? You read, remember how Australia addressed skin cancer: slip, slop, slap, wear sunglasses and a hat, right? It was a public health model approach. So for me, if you look at and we know there's a voluminous literature on the side effects of psychotropic medicine, and one of the most concerning things is that many of the side effects are not reversible, right? So if you were to take a public health model, we know that there is going to be a high use. How do we guide and protect and regulate the prescribing of psychotropic medicines? So we take a public health model. So for example, when I was working in one particular jurisdiction, that was the model we actually had proposed. It didn't get up, although it had support from health and a range of other bodies and professional associations. And that's how I think it should be approached. It's just that we are parking it at the provider level, and for me, practitioners and providers have no control about the prescribing. So that's why I think a public health model would be useful. Also, a public health model is a way of saying, there are deleterious side effects on the person. So if we take a public health model, for me, anybody having more than 2 psychotropic medicines should be reviewed independently by a panel, for example. At the moment, we have panels that lump all the restrictive practices, like in in, uh, in New South Wales by panel members. In Victoria is the Senior Practitioner Office. In fact, I'll give kudos to the Victorian Senior Practitioner Office. I think they had, among all the authorizing heads and bodies, they have one of the strongest and firm position on chemical restraint. Uh, and I say, if you take the public health model approach, because we know that over time it has deleterious effects on the person that are irreversible. So that's just kind of, and I predict it will continue to grow, because over the, so I've scanned the literature on psychotropic medicines with my colleagues internationally. It hasn't changed.
It hasn't changed.
It hasn't
So
changed.
the model now is not working.
No. Clinical guidelines, guidance, everything just does not change. The good news recently I've come across is the Victorian chapter of psychiatrists that had a position paper and concerns about the use of psychotropic medicines for people in a mental health area. And that's a good position paper. And I think more of that kind of should come from the Royal Colleges, in my view. As I say, because if you take a public health model, that's a good example of it. Many years ago, that I'm aware of in Australia, where there was the use of the behaviour nudge theory, to change behavior. You just need a little nudge, and there was an overuse and high use of antibiotics in Australia. And I think the study showed that with the Department of Health, when the Chief Medical Officer wrote to general practitioners, expressed concern about the high use of antibiotics. When that letter went out, they tracked it. The prescribing of antibiotics reduced.
Really? So there's proof of concept.
That's
of
proof
this,
of concept. Yeah, and
of this working elsewhere.
It uses a behavior nudge theory approach. Then for me, going back to my earlier point about the dollars and cents of restraint and seclusion, right? We know that the side effects of psychotropic medicines are many, right? It will reduce saliva production, and that would then impact on swallowing. And there we go. Now you have to, refer to a speech pathologist. The person, with a swallowing difficulties or dysphagia might be admitted to hospital, and worst of all, the risk of death, for example. We also know that many other side effects over time that are going to be costly to the health system. People, from their chronic lung disease, metabolic sort of issues, constipation, and it is actually a tax on the health system. So that's the economic sense that we have not thought, I think, deeply about in terms of the use of chemical restraint. Because the chemical restraint, not only does it have a negative impact on the person, but it also has an economic cost, because the person would have to seek medical attention, health services, and all these are actually cost.
So it's sort of communicating that although this may look like a quick fix, a quick win to implement a restrictive practice, the downstream effects.
Correct. Because there's studies that I'm aware of that track the, in fact, there's a lot of studies of side effects of psychotropic medicines that have been done. Most of my readings have come from the UK, from works of Professor Johnny Metzen in the United States. My readings have come from the Netherlands, and they all say the same thing about the side effects of psychotropic medicine, and there's an overuse of psychotropic medicines. People are using off-label.
Mm.
Uh, and so there's enough attention in that space. I think it just needs a tipping point.
Mm-hmm.
You know, when the, I think it'd be great to see a study on tracking the use of psychotropic medicines over time on people.
Mm. From a like an on the ground point of view, what would you say to a practitioner who is supporting somebody and there is, let's say, a restrictive practice that's a psychotropic medication prescribed to one of their participants, and the psychiatrist or the prescriber has just prescribed it and they've signed off on it and said that it is a restrictive practice? Like, what sort of conversation do you think a practitioner should be having with the prescriber?
So one of the things to be in terms of particular to psychotropic medicine is if you frame it as even as a rights perspective, if you are concerned as a practitioner, remember that the person, the participant, has a right to a second or third medical opinion. And we need to prompt, support that person to exercise that right, that of seeking a second, third medical opinion. This is a right available to any one of us. And I think we need to support the family and all that to understand and how to exercise that right. The second thing I've followed the work of Professor Shumitru Deb from Imperial College London. He has got a nice project called Spectrum, which is a psychoactive education system approach on the use of psychotropic medicines. His premise is, if we educate staff, families, the person with disability about the side effects of psychotropic medicine, then hopefully there'll be less use of that. When people understand what are the side effects of that. It's a nice piece of work that now there's a trial project that has been published. I understand it's now taken up by the University of Canberra, who's translating the work of Professor Shumitru Deb into Australia. And so education is another thing too. The third thing I always say, every time when there's you see more than 2 psychotropic medicines being prescribed, as a practitioner, one of the first things I will also query is, particularly where medication with impact on swallowing, is seek a referral to a speech pathologist, for example, because they are what I call, these are alerts that we should be considering.
It's a trigger. They trigger the next.
Yes, right. It should trigger your next question, your next probing, and that for me is important for the practitioner to have that kind of conversation. I'm also interested or curious, Aaron, in your work at Bespoke, with say at your team leader level, how does your team leader build this type of conversation with the practitioner about the use of restrictive practice?
So for team leads, I think that there has to be a really big emphasis on the skill development of the practitioner. So I find a lot of the time supervision can stray into just being case consultation. It can stray into just being about putting out fires that have come up that week. And then there's not enough time left for skill development and technical proficiency. And I think that helps a practitioner really build confidence in this area. Like, I find that especially if you've got a newer prac who has grown quite a large caseload quite quickly, then they're just going to be, there's 5 things I need to talk about in this hour. They've got 12 minutes each, and I've got no time for anything else in terms of development of myself as a practitioner. So I think that it's really important to isolate that and to have that time, to have that care. Like something that we have at Bespoke is like we have our monthly group trainings that we do, and like that's really cool. So we have people who send through like questions or things that they have struggled with over the month, and then we deliver trainings um, based on that. That's sort of within our governance cascade as well. Um, and I agree with you wholeheartedly about education and advocacy being really big for everybody. So there's the family, there's the stakeholders, there's the participant themselves. But then that goes all the way through. Like you were talking earlier about the accountants, and I agree. Everybody can advocate. It's not just somebody who is directly participant facing. So I would like to build a culture of advocacy, and we have that at Bespoke. So the if there's a practitioner there and they're unsure, they're a little bit confused, or they're not sure on next steps, it's about them feeling comfortable with bringing this up. Like if you've been a prac for a year or two and you're not sure whether something is seclusion, you're not sure whether it is a chemical restraint, you've maybe got the family pushing for it, you've maybe got a psychiatrist like just blowing you off, like who is this guy, who are you to question my prescribing, and to have the dynamic with a team lead where they're really supportive and they can have your back, I think is important. And there are some really nice position statements as well. Like there's so much help out there if you feel like it's not coming from the team lead. There's a lot of, we've got one of our team leads is just, he's incredible and he knows legislation just back to front. I swear, I don't know how he does it. But it's incredible to have somebody like that. Oh, he's unreal. He would have read a lot of your work. But yeah, to me, I think that they're probably the most important things. I guess my last question to you is, how has this changed in the last, I guess, like 10 years since the paper was published?
Well, it kind of begs me to say perhaps it's time for another paper
Yeah.
in this space, particularly in the Australian context of the NDIS. So I actually think that there is scope to um, to do a study just in this area about the dollars and cents of um, restrictive practices, because that was done in 2012. So, and that was, by the way, also an international kind of analysis. I think there's scope to do a very specific Australian study of analysis. Um, my bet would be there would not be there. Um, there's be very little change. Very little. I've been training and teaching people about the myth and assumptions of restrictive practices. My PowerPoint slide has been, which I developed was nearly 15 years ago. Every time when I go back to it and find new literature or research evidence, it's very disappointing because nothing significant has changed.
Wow.
And I don't know. It's not just peculiar to Australia. I also have been reading internationally, like particularly from the UK, at least more recently even in New Zealand, that very little has changed, and that worries me. For me, it goes back to how do we view people with disability, and I still think that is one of the that's why in our first conversation, when I talk about every time you use a restricted practice, it's a failure in the support system. I also think it's a failure because we don't understand people with disability. And there is that kind of view, and it goes back to my initial thoughts of how I moved into mindfulness-based positive behavior support. We still act on, prod, poke on the person with disability.
Mm-hmm.
And I think it needs a paradigm shift. What if we do things outside? Do we intervene? And there's, in fact, quite ample literature in this space. It's also the use of restrictive practice, and people need to understand this very clearly. It's actually a risk mitigation approach. Restrictive practice has no therapeutic value. It has no efficacy. Although some people might argue it is efficacious, for example, like mechanical restraint. If someone's hitting, or self-injurious behavior, you put a cast and you stop the person, and then there you go, you stop the hitting, right? The mechanical restraint is efficacious. But what people don't understand, over time, when you keep applying the mechanical restraint, the cast on the person, there's also in fact, we've created a psychological, I think, unconscious reliance on something. There's also impact on muscle tone over time if you don't check it carefully. It's just that when we apply a restrictive practice, as you stated, kind of related to what I'm going to say next, that in 6 months' time, what is the impact on the person? And can you imagine if you apply mechanical restraint every time, or even environmental restraint, the front lock door, over time? There's an impact that we don't see because we're only addressing it as a risk mitigation strategy. The person's safe. But then over time, locked front doors, locked kitchens don't promote skills development. You create an artificial environment where the person is independent. I also think you create learned helplessness. And these are some of the side effects about restrictive practices that we don't see. So your point about checking on what is the impact on the person 6 months later, 12 months later, I think it's an important point, because we make decisions on people with disability sometimes without thinking that what is the impact over time.
What capacity are we building?
Exactly right. Exactly right. Because you don't build capacity, you don't build capability. It's a risk mitigation strategy.
It's quite blunt. It's not nuanced. It's quite final as well.
Yes, right. Yeah. And so one of the studies I think that I would like to revisit, perhaps it's a study we should do. One of the things I like to revisit is the study done by Paul Remcharan, which is the first study that I'm aware of in Australia that looked at the experiences of people with intellectual disability when they're subject to restrictive practices in Victoria. And their insight, the insight of people with intellectual disability about their experiences was so important. So, and that in that study, the people with intellectual disability came up with the term, my behavior is not a challenging behavior. My behavior is a behavior of protest against a maladaptive environment. If the environment is maladaptive, my behaviors are responding to that. So it's a behavior of protest.
What a reframe.
I love that reframing.
Wow.
I still go back to that study. And one of the things I'm proud about that study because I funded it, it was the first time where we trained people with intellectual disability in Victoria to be researchers. So it's not a tokenistic approach. They were trained to be researchers. They helped design the methodology. They created the vignettes. They interviewed their peers in the study, and they co-wrote the paper, although I think it could be a simpler paper, but hey, there was that time. So it was quite a... so I always say, apply, this is where mindfulness is so helpful, apply from the perspective of the other person. See it from the other person's lens. And then when you see it from their lens, it's like, yeah, my behavior is a behavior of protest.
Yeah.
It's actually an acceptable behavior when it's an environment that's maladaptive. Because we use about, people with intellectual disability about their maladaptive behavior. But the environment can be maladaptive, so my behavior is actually appropriate.
It's appropriate and proportional.
Proportional, and that's I just am today still guided by that paper, that reframing, because it changes your whole perspective.
I would love to revisit that with you. I think that is right to go.
Yeah.
Jeff, I really appreciate your time. This concludes the second episode. Always a pleasure, and we will pick this up again next time.
Terrific. Thanks so much, Aaron. This is fun.
Thank you.
Thank you.